morning, everybody. I am Julia from Department of Rehabilitation Medicine, Malaya, and I have the pleasure to introduce you to the first speaker, Professor Kristi Kirschner. Professor Kristi Kirschner is a clinical professor from the Department of Medical Education, University of Illinois College of Medicine, Chicago. She is also a rehabilitation physician specialized in neuro rehab, and she is our visiting professor at the Department of Rehabilitation Medicine. And her interest is in clinical ethics, rehab ethics, and also disability studies. And with this, Prof. Kristi, please, the floor is yours now. Thank you.
Thank you, Julia. So we've only got a short time together today, but I understand I have an audience of people with different backgrounds. Though my background is in rehabilitation medicine, I also work with learners in the College of Medicine and help direct our ethics and humanities curriculum. So we're going to talk a little bit about how moral distress is distinct from, sometimes similar to, ethics issues, and how we would describe ethics issues that are really sort of unique or particular in the practice of rehabilitation medicine. I'm going to just give you a brief overview of the kinds of issues that come up in rehabilitation practice. And I'm going to close with a discussion of why we really want to think about addressing issues of moral distress in healthcare when they arise. So I think you've got a pretty good sense of me. I went to University of Chicago for medical school. A few years later, I went back and did an ethics fellowship there. I've worked in rehabilitation my entire life. I'm now at the University of Illinois College of Medicine, where I'm working on developing a lifespan disability clinic, and I run the ethics and humanities curriculum. But ethics has been of interest to me going back to even my college years. When I was a resident at the Rehab Institute in 1987 to 1990, there was a working group in one of our very early original ethics centers in the United States that engaged in conversations about what was similar to and different about rehabilitation medicine. A lot of clinical ethics had talked about autonomy-based principles, informed consent, assessing decisional capacity, end of life, beginning of life. So many of those issues had been fairly well articulated by 1987. But in rehabilitation, we were dealing with issues of chronic care, living with disability, oftentimes with social issues that interacted with the disability. In rehabilitation, our issues play out over a longer period of time. Patients often come and stay with us for weeks at a time if they're in the inpatient rehabilitation setting. Families often are very involved, and the patient has to be engaged. They have to be a willing participant in their care. So this working group articulated these issues as sort of the salient things that made rehabilitation ethics different. The model of care is different. It's focused not on cure, but it's focused on restoring the person to maximal functional ability, restoring self-determination so the person has agency over their life again. It's delivered by an interprofessional team that work together around identified goals. Patients' values are absolutely critical in terms of rehabilitation. Everything is set around the patient, what their living situation is, what is important to them. Quality of life becomes a big consideration, and that's always in the eyes of the beholder. We have lots of resource allocation and social justice issues. who even gets into inpatient rehabilitation is a starting point for many of those discussions. You can have two people with the same condition who have very different economic and social circumstances, and that can also create a lot of difficulties in terms of the provision of care. Family surrogate decision makers are often involved. Decisions about when rehab is ended is also always a judgment call and can be a fraught issue. And there are professional and interprofessional standards in rehabilitation practice. So that work was going on while I was a resident. I graduated in 1990, which was kind of a big moment in the United States, particularly for those of us who worked with people with disabilities. We passed the major civil rights law for people with disabilities. People were to be included. They were supposed to have considerations in terms of the environment and resources and supports and accommodations. We had a lot of high expectations at that moment in time. I also took a job immediately out of my residency working as a spinal cord injury physician. In my work, I got very interested in the issues of reproductive health care issues for women with disabilities. They're a minority in spinal cord injury care. And I learned in my outpatient clinic that many of them weren't getting services, that the clinics weren't accessible, that people did not see them as sexual beings, as able to have babies, be parents, be in loving relationships. And so we began to work on those issues and try to integrate women with disabilities into reproductive healthcare services. Through that work, I was introduced to the independent living movement and to disability studies. Disability studies, for those of you who haven't heard of that, it's a young field. It's an interprofessional, interdisciplinary lens that looks at the concept of disability, and it looks at it from different conceptual models. Specifically, the social model has been prominent. That disability in and of itself is not always negative. It doesn't just reside in the individual, but it's an interaction between the person and the environment. The environment can disable someone by being inaccessible and not providing accommodations. Through that work, the principle, nothing about us without us, became paramount. And everything I did included people with disabilities in the conversations and in the direction and setting goals for the programs. We also started to have a lot of conversation about physician-assisted suicide and euthanasia in the early 1990s. A renegade physician, Dr. Kevorkian, had developed a suicide machine. He was using it on people. He's a pathologist by training, but he was making decisions that many people didn't have a quality of life or a life worth living, and he was helping them die with his suicide machine. In retrospect, when we looked at how many, it was well over 100, and about 60% of them were people with disabilities. So it was an important issue again that we were beginning to grapple with as a society. As a rehab clinician, I had a pretty strong feeling. I hadn't been trained about disability in medical school. It wasn't integrated into healthcare training programs across the board. Clinical ethicists weren't trained in the particular issues regarding disability. And it became clear that there were gaps between knowledge and between experience about important things like prognosis, delivering information about resources and supports. I also came to realize, and this may not be true in your country, but in my country, I realized that many people with disabilities were very angry at the healthcare system. They didn't see us as allies. They saw us as people who were trying to cure, normalize their bodies and not support them in adapting and living with their disabilities. didn't welcome them in their spaces. So that was another issue that I thought deeply about early on in my practice. There was oftentimes a disconnect between the way people saw their own lives, what was important to them, and the way others saw them. And we don't have time to unpack this today, but there's something called the disability paradox, that people who live with disabilities tend to have a much higher view of their quality of life than the external observer who's never experienced the condition. Healthcare professionals in particular are guilty of these views. So, and I've already mentioned that clinical medical ethics was focused on beginning and end of life, not the chronic care, rehabilitation, and disability issues. As a resident myself, I found myself really struggling with some clinical issues that came up in my own work as a resident. And over time, I wrote about them. I wrote the article about the tracheostomy tube, where we had an 18-year-old boy with a new onset disability, far from his family in our rehab unit. He'd been decannulated. I was the resident on call, and he was decompensating. And I thought that the trach might need to go back in. So this young man, just 18, newly disabled, said he'd rather die than have me put that trach back in. And I was in quite turmoil, trying to decide, would I really accept that as his authentic wish, autonomous decision, particularly so soon after spinal cord injury, where he didn't know what his life might look like. I also wrote about a patient I took care of who had a right hemispheric stroke. She was quite articulate. She could tell you what happened to her. She could tell you she wasn't supposed to get out of bed without calling for assistance, but she did it repeatedly. And one night she fell and she broke her hip. And she had to have a hip replacement. And then she was supposed to adhere to our hip precautions, not bend forward beyond 90 degrees, externally rotate her hip and whatnot. And the problem was that she also decided she was going to discharge herself from the hospital against medical advice. She didn't want to be there, and she had no family or support. So this psychiatrist was called to do a decisional capacity evaluation, and she verbally met all of the criteria. She could tell you what was wrong with her. She could tell you what the precautions were, and they deemed that she was decisional. And I know that didn't sit right with me, and I was very, very troubled because she had a behavioral disconnection syndrome where she might be able to articulate, but she could not behaviorally connect the two sides of her brain to follow through. It was a brain injury, I felt, that had caused the difficulty. So it was a really difficult issue for me because the traditional clinical approach to decisional capacity assessments I didn't think fit her. So that was kind of the prelude to entering into my ethics fellowship. I felt like I really wanted to think more deeply about the way clinical medical ethics had approached issues and apply them to disability and rehabilitation ethics. There was no training on these issues actually during my ethics fellowship. Ethics consults oftentimes had disability issues involved, but there was rarely, I felt, an informed discussion about prognosis or functional outcomes. There was oftentimes a discussion about what would you want if that were you. So I ended up with my colleague, Dr. Katari, writing an article about, is using the golden rule appropriate when we're making decisions and recommendations on behalf of others? Our take-home message was no. If you haven't experienced a condition, you don't know what it's like, our imagination is not a very good starting point. So I did a survey as part of my ethics fellowship on the kinds of issues that rehab clinicians were experiencing. And we found across the board, looking at all clinicians, physicians, nurses, social workers, PTs, OTs, everyone on the rehab team, that there were a lot of issues. And we got a very good response rate. 217 clinicians responded, and they told us that we were living in a time of turmoil where healthcare reimbursement pressures were creating a lot of havoc in terms of being able to get the care that patients needed. There were conflicts over goal setting. And again, these issues over assessing decisional capacity were fraught issues. We set about trying to develop ways of intervening to work on those issues. And before I go further, I want to just define that everything in medicine actually is a moral enterprise in some ways. Ed Pellegrino said, medicine is a moral enterprise, and he unpacked why that's true. We're going to accept that as the premise. But in medicine, we've got what are called ethics dilemmas. You don't know what the right course of action is. It's not clear. You got competing values and principles, obligations. Whereas moral distress is you've got a sense that you know what the right thing to do is, but you're prevented from doing it. And this came out of the nursing literature, which I think is really important because of the hierarchical nature of nursing. And that it's now moved into the medical literature as well. But the whole idea is that first we have to become morally aware. We have to be able to define the moral parameters of the situation. When we feel blocked from doing what we believe is the right action, we're going to experience feelings of moral distress, which I'll describe more in a minute, that can lead to moral injury and eventually burnout. The medical literature, particularly regarding trainees, is talking more about this experience. I recommend this article if you're interested in learning about moral distress that occurs in the US in internal medicine residents. But they talk about, sometimes it's connected to the hidden curriculum, that you were taught things the way it should be, but you're in your residency and you're witnessing behaviors that are counter to what you know is the right thing to do. And it may be negative role modeling or substandard patient care. This kind of distress can cause us to become avoidant, disengaged, cynical, decreases empathy, and it can lead to profound difficulties both for the individual and for the profession at large. So I'm going to share with you just an example of what this might look like with the rehabilitation resident. And as we're looking at this case, I recognize that I want to leave a few minutes here for discussion. Let's have you think about, what do you think she's experiencing? What do you think the values are in conflict, and what is at stake? So the story is she's a second-year resident in rehab. She approaches a colleague and says, I'm really in distress. I admitted this patient with severe traumatic brain injury today. And the family just said right off the bat, we are so excited to have him here. We know you're going to fix him. You're going to cure him. He'll be able to be fully himself again. And they said that, the team that transferred him to rehab told him that's what's going to happen there. And the resident's assessment was not likely. He's got a very severe brain injury, and she tried to temper their expectations by giving them some information about how brain injury rehab works, how we, figure out prognosis over time, but they weren't willing to hear it. They didn't want to hear it. They weren't willing to discuss a backup plan. If he couldn't return to work, be himself, able to care for himself, they were unwilling to have that discussion. So I'm going to give you all a chance to put in chat or unmute and tell me, what do you think she's experiencing? What's going on here? Is it a moral issue? Do you see this as an ethical dilemma or a moral issue? I'm not seeing chat, so if anything's popping up, oh, wait a second. Yes. Awkward situation. Yes, unrealistic goals for family. Absolutely. Any other thoughts? Well, let me keep moving here again, so we've got a little time for questions. But the way I would characterize it is she's feeling disempowered. Maybe she's feeling angry. Maybe there's a sense that there's been some disrespect of her expertise. And maybe there's some moral distress. So let's unpack this a bit. The family was given false hope. And when that occurred, it undermined her authority and the authority of the rehabilitation team to combat the misinformation they had been given. It's a fraught time when somebody is newly disabled to have to figure out how to balance expectations and prognosis while rehabilitation proceeds. I'm sure in the back of her mind, she's thinking, she's got the responsibility of now caring for the patient, but she's worried that maybe they're going to blame her if those goals are not achieved. So the values I see in conflict, her professional autonomy and her desire to do good and at least do no harm on behalf of the patient, are really important values, ethics values that are at stake here. There's a hierarchical nature. She's a resident. She's working as part of a much larger medical team. Certain specialties tend to have higher status than others, and that can also cause problems. The goal setting, who gets to decide on goals? How are they arrived at? Lack of understanding of what other team members believe rehabilitation is and what areas of expertise they have. Thank you again. I'm appreciating these comments. So this is a difficult situation, and there's a lot at stake because it's going to be a lot harder to work towards common goals in the best interest of this patient. So moral distress here, is this feeling of discomfort, frustration, anger, powerlessness is oftentimes a very prominent feeling. And if you can't remove or resolve the inciting factor, it can build. And it can also be intervened with in such a way that you can experience moral success. You can resolve it, and that empowers you. So I'm going to move quickly here. The way moral distress can unfold is you can continue to have moral residue. Something doesn't get resolved. Something happens again. There's more moral residue. It crescendos, and there can become a sense of futility in having agency and the ability to provide care. So I'm going to move through these slides. These are slides that really help us unpack what issues we see. And I wanted to call out Dr. Julia and Dr. Mazzolina's study back from 2011. I had 2 surveys about rehab ethics issues in my hospital. The things I want to say as take-home messages is we shouldn't ignore these things. We need to engage. We have to first develop the language to identify it, to name it, to be able to identify what are the values in conflict, what's at stake if we don't resolve it, what's at stake if we can, and how do we develop a better system for trying to work on these issues. There are tools to do this, and I'm just calling out a couple here, and I think they're very good, again, coming from the nursing literature, but they can help take us through a process of discernment. We have to consider what's at risk, particularly when you're in a hierarchical system. There's some risk in terms of speaking up, but there's also risk in not speaking up. And we have to look at external barriers like institutional problems, resources, hierarchical differentials, policies, legal constraints, as well as imposter syndrome, fear of consequences. If you speak up in a hierarchical system, you may fear that there will be repercussions. But at the end of the day, there's also a risk of inaction. And our goals in healthcare are to align our values and behavior to achieve the best care for patients, ensure healthy team communication, respect the role of all team members, including those who aren't MDs, and preserve our integrity and trust. So by addressing moral distress, it can lead to positive change. In the United States, we've been tracking these issues, particularly since COVID, because there was such incredible moral distress in the wake of COVID, where people felt their hands were tied and they were unable to have the tools that they needed to provide the care. This actually, though, demonstrated that before COVID, we had plenty of issues of moral distress, particularly with the corporatization of our healthcare system and the inequities. So this is also an issue where we have to attend to the health of our workforce. We have many people who in the US are admitting they're burned out. They're talking about whether they want to retire or change jobs. So I think that not addressing it has profound implications for the health of our medical systems, but we also need to have good information. So I think going back to trying to get data on what are the issues that really are impacting the people you work with. So I'm going to close by just telling you, hot off the press, there's a new survey that's still getting results. We've got some preliminary results, but this is by our colleagues in rehabilitation at the Rehabilitation Hospital and the master's program. Dr. Coelum Gunnison has been the lead investigator with Dr. Meslina and Dr. Julia, and I have also been involved. So stay tuned. This is coming. I think we just have a few minutes for questions, but I'm happy to entertain
Right. So
that you have.
yeah, thank you, Kristi, for giving us. It is such an elegant lecture, I find. Yeah, I think we have only one time for one question. There's only one question. Is it important to differentiate whether it is a moral or an ethical issue?
You know, I think it's important to try to name what kind of a moral issue it is. So ethics is oftentimes thought of as the study, the discipline. So moral issues are related to ethics. You know, ethics is what's the right thing to do and how do we discern that. Moral issues have a little bit of a different flavor because they're related to our character, our upbringing, our social values. But I think trying to characterize it as what bucket it's in. So we've got a process or a mechanism to try to move forward and figure out what to do about it. Does that help?
I suppose so. I think, yeah. So we don't have any question, and I think we are just short of 2 minutes before the next session start. So I would like to thank Prof. Kristi for spending her evening with us. And I hope that we have learned a lot of things from her lecture. Thank Prof. Kristi. So I give way to the next speaker or the next session to start. But to you, Dr. Cho.